We now move on to the talk on preoperative investigations evaluation and role of imaging in white cataracts. So good afternoon everyone. I'll take you through the preoperative evaluation and role of imaging in white cataract. There are no financial disclosures. So the challenges in a white cataract are the absence of a red reflex, difficult capsulorhexis, and lack of an epinuclear cushion during nucleotomy. We'll cover all of these aspects in our subsequent talks as well. And comprehensive preoperative evaluation and planning help to achieve optimal outcomes. So preoperative evaluation in focused on evaluating the morphology of white cataract. Essentially, the intralenticular pressure, if raised, should be assessed preoperatively to help you plan better. Then the nuclear hardness, because despite all the advances in phacoemulsification, for some you may still need an intracapsular extraction. Ocular examination, rule out any raised intraocular pressure, and posterior segment evaluation because you will not be able to see the fundus. IL-PAR calculation and accurate biometry. So the conventional classification system classifies as mature, hypermature, or Mergagnian. Slit lamp based classification classifies given by Basti et al. Was useful because it classified the intralenticular pressure as raised or not raised, intumescent and non-intumescent cataracts respectively. The status of the cortex, milky in hypermature and not milky in mature, and the nuclear color, brown, brunescent, or opalescent white. Then Brazitikos et al. Gave a classification based on the biomicroscopic appearance, A-scan findings, and intraoperative peculiarities. So they classified as type 1 with a diffusely flocculent cataract and raised intralenticular pressure, or the intumescent swollen type of cataract. Then type 2 cortically mature cataract with flocculent cataract and a hard brown nucleus. Type 3, which was a uniformly soft cataract with gelatinous cortex, which is the easiest to manage. Preoperative assessment of raised intralenticular pressure is essential. It cannot be stressed enough because this is going to tell you how your rhexis is going to behave. So on slit lamp examination, you can see a bulging anterior capsule with a relatively shallow AC and the presence of intralenticular clefts that tell you that you will have likelihood for an Argentinian flag sign. Anterior segment OCT is a very useful tool. The increased convexity of anterior capsule and intralenticular clefts can be clearly visualized. As Dr. Namrata showed in the video, intraoperative OCT has emerged as a useful adjunct not only to planning but also to decision making and managing the case as you go. So we gave an intraoperative OCT based classification in which white cataract was classified in 4 types based on the appearance of the morphology of the cataract. So type 1 had regularly arranged lamellar cortical fibers with minimal intralenticular clefts. This is the one that behaves the best during rhexis and is the easiest to manage. Type 2, with these increased convexity of anterior lens capsule, hyperreflective bands of swollen cortical fibers with intralenticular clefts is the most challenging to manage. This is the one that will typically have an Argentinian flag sign the moment you give a nick. Type 3 has a combination of hyperreflective cortical bands with intralenticular clefts and regions of homogeneous ground glass appearance. So this homogeneous ground glass appearance is the liquefied cortex that is going to come out and cause some decrease in the intralenticular pressure, and these clefts are the one that clefts and the hyperreflective bands are the one that contribute to intumescence and are going to lead to extension. Type 4 has a uniform homogeneous ground glass appearance of the anterior lens cortex. These are the one in which a lot of milky fluids come out the moment you give a nick, and there is a release of intralenticular pressure, making the subsequent rhexis still challenging, but you do not see a Argentinian flag sign in these. So just to give you a clearer example, in type 1, you can go ahead with the rhexis. There is no release of turbid or milky fluid, minimal disturbance of underlying cortex. Type 2 is the one which is the most dangerous, and in fact IOCT told us that we could see a bulge the moment we initiated the rexes, and this is the intumescent that leads to an extension in capsule if not managed properly. So either you do a cortical aspiration, bimanual aspiration to decrease the ILP and before progressing further, and always go for a smaller rexes followed by secondary enlargement, either spiraling. And bimanual IA is needed to relieve the intumescent. Just a brief video of the same type of cataract. So once you initiate the neck, you can see the fibers coming like a hill, and since they are continuous, the continuous cords do not allow release of intralenticular pressure, and a dispersive OVD helps flatten the capsule, and intumescence can be released with a bimanual irrigation aspiration before you further progress with the capsulorhexis. Type 3 is a mixture of type 2 and some liquefied fluid, so it's progressed beyond that, and there is some release of fluid, but the intumescence is not completely relieved. So even though it is better than type 2, still there is an imminent risk of extension, so you have to proceed carefully with a spiraling capsulorhexis. So you can see there is fluid release, which liquefied fluid release, and the intumescent is not as continuous as in a case of type 2 cataract. Type 4, there is a turbid fluid release. You can see it even without an OCT as well, leads to a release of intralenticular pressure. The challenge now is that there is no support while doing a rhexis, so prefer a forceps rather than a cystotome. Moving forward with the ocular examination, you have to rule out any ocular comorbidities. Systemic evaluation and preoperative optimization is essential. Pupillary dilatation should be assessed, endothelial cell function, intraocular pressure. You have to rule out phacomorphic or phacolytic glaucoma. Anterior chamber depth has to be assessed, anterior chamber phacolytic material, uveitis, any subluxation or zonular weakness, because these cataracts are as it is prone to develop zonular weakness. Then assessment of visual potential, because total cataract is going to obscure the visualization of the posterior segment and may hinder adequate assessment of visual potential. So pupillary reflexes, because RAPD may point towards optic nerve conduction defects. Projection of rays should be accurate. It will give you a gross estimate of the retinal and optic nerve function. B-scan ultrasonography to rule out retinal detachment and vitreous hemorrhage. Axial length optical biometry may not be possible, and A-scan ultrasonography or immersion axial length is required for accurate assessment. Keratometry, again fixation may be difficult in white cataract. With the newer optical biometers, you may achieve accurate optical biometry. Often you may have to resort to conventional keratometry techniques as well, and pupil-based centration for keratometry assessment is preferred. Assess the fellow eye status. Is it phakic, pseudophakic, or a phakic? If it's phakic, assess the relative anterior chamber depth. Maybe you can see the morphology if there is a hidden posterior polar cataract, if the other eye is not a white cataract, and posterior segment evaluation can be performed. In pseudophakic and aphakic eyes, complicated cataract surgery, PCR, may give you an idea of how difficult this case can be. Posterior segment status and visual potential, of course, can be assessed in the fellow eye. Written informed consent is a must. Preoperative counseling, address the patient expectations, inform guarded prognosis and potential complications. A lot of patients opt for premium IOLs in intumescent white cataracts. You have to be careful while counseling because the surgery may not go in an exactly predictable manner. Just to summarize, a comprehensive preoperative evaluation is the key to optimal outcomes. Ocular examination to rule out comorbidities and accurate biometry. Morphology has to be assessed to rule out raised intralenticular pressure, which can help you plan better. The amount of nuclear sclerosis, and pre and intraoperative imaging is a useful adjunct to planning. Assess the visual potential in terms of pupillary reflexes, projection of rays, and B-scan ultrasonography. Informed consent and counseling is the key. Thank you for a patient hearing.